This video constitutes part 4 of the thoracic imaging lecture series. So specifically, we'll be going through a couple of main examples of abnormalities and pathologies as seen on chest x-ray. Specifically, we'll be discussing the principles of consolidation, atelectasis, and then followed by pneumothorax and closing with chronic obstructive pulmonary disease. So at a second year level, it is critical that you're able to differentiate between normal versus abnormal radiographs. And what is more important rather than interpreting the pathology is actually having a systematic approach to interpreting and assessing radiographs for abnormalities. So two of the most useful signs to consider when looking at chest radiographs is going to be the silhouette sign. The silhouette sign is in essence the elimination of the silhouette or a loss of lung or soft tissue interface which is caused by a mass or fluid in the normally air-filled lungs. So in other words, if an intrathoracic opacity is in anatomical contact with, for example, the heart border, then the opacity will obscure that border. This sign is commonly applied to the heart, the aorta, the chest wall, as well as the diaphragm. And the location of this abnormality can help us to determine the location anatomically. So what we can see on the x-ray above is the loss of the right heart border. We know that this is going to be in direct contact with the right middle lobe, so we can see that we have consolidation in the right middle lobe, which is going to be indicative of lobar pneumonia. In addition to this, an air bronchogram is going to be a characteristic sign of consolidation. And essentially, a bronchogram is going to be a tubular outline of an airway which is made visible by filling of the surrounding alveoli by fluid or inflammatory exudates. So the drawing above is courtesy of Radiopedia, where we can see the black surrounding is going to be the lung parenchyma, and then the white illustration is the attempted drawing of the pulmonary vascular tree. In a normal radiograph, you should be able to trace the pulmonary vasculature from the medial hilum of the lung through to the lateral periphery. As we can see here, if we trace all of these vasculature, they should be extending to the periphery. So remember that the vasculature is going to be a semi-radiopaque density, so it's going to be hypodense in comparison to the lungs, as well as the alveoli, which are going to be located posteriorly. And as a result, you shouldn't actually be able to see the alveoli. So by having the difference in the density between the vasculature, the alveoli, and the lungs is the reason why we can actually see the interface in the form of the vessels. However, as soon as you start to see airspace opacity arising, as illustrated in black here, the alveoli space is filling with pus or fluid or hemorrhage, you soon lose the ability to trace the blood vessels due to the fact that you'll now have a similar density and you'll gain the ability to see the airways moving through the lungs. This is termed or defined as a bronchogram, and it's essentially the same as a silhouette sign, but it's going to be to a much smaller scale. So if we're looking at areas of consolidation, you should see an increased opacity associated with the lung tissue, and you should also see a decrease in the airway opacity or alveolar opacity, which is going to be radiolucent, which is going to then be a key sign of consolidation. So the x-ray above shows us the nice clear tracings of these air bronchograms within that consolidated space. So just carrying on with the notion of consolidation, pneumonia is going to be the far most common cause of consolidation, and the disease will usually start within the alveoli and then spread from one alveolus to the next. When it reaches a fissure, however, the spread is going to stop there, and that is why we have the ability to differentiate particularly lobar consolidation, as it's going to be localized to a particular lobe or segment. So if we look at the x-ray above, we can clearly see our nice air bronchograms. If we trace the cardiomediastinal contours or border, we can see that we can clearly see the left hemidiaphragm. However, we have lost the clarity and the definition associated with the left heart border. This indicates that the consolidation is going to be localized to the left upper lung, and our air bronchograms are going to be a key sign of consolidation in this patient. So for the purposes of this lecture, I'm only going to focus on lobar consolidation, as this is the most common presentation, as well as segmental consolidation. And in a typical lobar consolidation, the key findings are going to be increased density, as well as ill-defined borders in the left lung. The table above is going to summarize the most common diseases that are present with consolidation. It is not expected that you know this, but it is important just to recognize that obviously there are different contents that are going to cause or present as consolidation, and we have three main patterns, which is going to be your lobar, diffuse, and multifocal. So we've gone through the main findings associated with lobar consolidation. If we look at this example over here, if we trace our right heart border, we can clearly see that we have actually lost the ability to define that border. Since the right middle lobe will be in direct contact with the border, we can see an increased opacity, which is going to be indicative of consolidation of the right middle lobe. We can also see our nice air bronchograms within this space. This is then going to be consistent with right middle lobe pneumonia. A 50-year-old female has presented with a shortness of breath as well as fever and rigors. So what we can see here, if we start with assessing our airways, we can clearly see our trachea, the carina, your right and left main bronchus. So there doesn't appear to be any deviation of the airways. Secondly, in terms of assessing the lungs, so the best way to assess the lungs rather than starting from medial and working your way out is to consider doing a zigzag pattern from the upper left and then scrolling across to the upper right and so forth until you reach the lower right or left borders. What we can see here is the right lung looks pristine. However, in the left lung, we can start seeing obscurity in this lower aspect. So we can still make out the cardiomediastinal border or margins. However, what we have lost is the ability to differentiate the left hemidiaphragm. So we can see that the left hemidiaphragm is now going to be the same density as the heart, as well as inferiorly by the superior GI structures, specifically in this case the stomach, as we can see air within the stomach. So specifically the loss of the left hemidiaphragm is going to be indicative of consolidation in the left lower lobe. We can also see there's a small focus on linear atelectasis in the left costophrenic recess region, so we have lost the ability to see the blunting of the costophrenic recess in contact laterally with the rib, as we can see pristinely on the right. But again, it's important to realize that it's not always possible to divide lung abnormalities into your classic four patterns, which are going to be your consolidation, interstitial disease, atelectasis, or masses. But that shouldn't be a problem. So sometimes you'll be confronted with an abnormality that will look like atelectasis and consolidation, or consolidation and a mass. What's important is just to be able to do the workup of both the differential diagnosis, and what is more important, again, at a second year medicine level, is just to be able to recognize an abnormal chest radiograph. So then moving on to our next case, we can see over here we have lost the ability to differentiate the right heart border. So this is going to be suggestive of consolidation in the right middle lobe. We can also see over here we have clear differentiation of the horizontal fissure. We know that this is going to be separating the middle from the anterior or the superior lobe. And accordingly, we can see that the consolidation is actually imposing or extending onto the anterior segment. So you would say that this patient has right middle lobe pneumonia. We can also see there's some moderate volume loss in the middle lobe, and we have consolidation of the right upper lobe. Also in the space, we can see the presence of your air bronchograms, which confirms consolidation. So here's a tricky one. So looking at the radiographs of A and B, I want you to think about which patient has been exposed to asbestos. So in patient A, we can see multiple calcified pleural plaques on the surface of the lung. So we can see this cluster over here, we can see another there, another one here, and then as highlighted in green. And this is going to be a hallmark of asbestos exposure. So these are classically described as being geographic, so looking somewhat like the continents of the world map as shaded in green. And in addition, on the diaphragm, we see pleural thickening, characterized by these thick white lines. So calcified pleural plaques themselves are benign and do not indicate asbestosis. Patient B, on the other hand, we can notice that we don't have pleural thickening on the diaphragmatic surface, and as we can see, we don't have as clearly defined plaques throughout the lung parenchyma. But what we do see is these areas of dilated bronchi within the right upper lobe, and this occurs mostly in asthmatics and produces what is described as a finger and glove appearance. So if we superimpose an image provided by Radiopedia, we can see this glove-like opacity in the right upper zone, as denoted by the yellow dotted line, and this is going to represent septum plug bronchiectasis. So then moving on to the concept of atelectasis, which results in and describes a loss of air in a lung or a segment of the lung, with subsequent loss in volume due to airway obstruction, as well as the compression of the lung itself by pleural fluid or a pneumothorax. So specifically, resorptive or obstructive atelectasis is a form of lung collapse that is going to be due to the obstruction of the airways that supply a lung or segment. It is a term used to describe atelectasis defined on an imaging based on underlying pathophysiology to guide the diagnosis. So there are a variety of different types of atelectasis, the most common being lobar atelectasis. The main findings of atelectasis are going to be sharply defined opacity obscuring vessels without an air bronchogram. In addition, you'll commonly see volume loss resulting in the displacement of the diaphragm, fissures, hilar, or mediastinum. So again, looking for the silhouette sign. So the appearance of lobar collapse or lobar atelectasis is going to vary depending on the lobe that is involved and will be discussed separately in this lecture. So firstly, when we're looking at the right lung, this can then be segregated into 3 common lobes and accordingly presentations. So firstly, with the right upper lobe, you will tend to see a classic tenting of the right hemidiaphragm. With the right middle lobe, we will see a silhouette sign associated with right heart border, as we have discussed previously in the case of lobar pneumonia. And then with right lower lobe, you will lose the right hemidiaphragm. So you won't be able to see the full shape and length of the hemidiaphragm from your costophrenic to the cardiophrenic recesses. So in accordance, you can actually see with the collapse of each of these lobes or segments, this will result in a decrease in the volume of the lung. And then secondly, with the left lung, if you see obscuring or silhouette sign associated with the left heart border, this is going to be classic of left upper lobe collapse, and then left lower lobe collapse is characterized by a loss of the left hemidiaphragm. Firstly, right upper lobe collapse will have distinctive features and is easily identified on a frontal chest radiograph more so than upper lobe collapse. So the key features with reference to this radiograph is going to be an increased density in the upper medial aspect of the right hemithorax. We can see the loss of the normal right medial cardiomediastinal border or contour. In addition, if we consider the relations of the left hilar versus the right, we can see an increased height or location of the right hilar, so it means that it is being pulled upwards, and we can also see this pulling or increased height associated with the cardiophrenic recess on the right. In addition, a telltale sign is going to be this classic reverse S shape, which is called the golden S sign, and it's going to be a sign that's highly predictive of lung cancer obstructing the right upper lobe bronchus. So just showing an annotated version of this image. So we have the collapsed segment up here, The line in white is representing our golden S shape. So red denotes where the horizontal fissure should be in its normal position, and then corresponding to the golden sign is actually where the fissure is now located. So just looking at another example provided by Radiopedia, the first thing that's going to stand out is going to be our classic golden S sign. So what we can see here is going to be a right upper lobe collapse due to a mass within the right hilum. In addition, if we try and locate the trachea over here, we reach the point of the carina and our bifurcation into right and left. We can see that we have pulling of the trachea and the airways to the right. If we then consider atelectasis of the left upper lobe, we can see firstly our airways are still pristine. So we have trachea in the midline, carina, right and left main bronchus. If we consider our diaphragm, the shape looks pristine on the right, and we can trace most of our pulmonary vasculature to the periphery. Notice this is a female patient too, so you can actually see the shadowing or the skin folds associated with the breasts. If we consider the appearance of the left lung, attempting to trace the cardiomediastinal contour, we can see the aortic knuckle, location of the pulmonary artery, and then clearly we can see obscurity or loss of the left heart border. So automatically we know that loss of the left heart border is going to be associated with the left upper lobe. In addition, we can see air bronchograms going through this space, which is going to be indicative of consolidation or atelectasis. So remember, the definition of atelectasis is going to involve reduction or loss of lung volume, which consolidation isn't. So automatically here we can see raising of the left hemidiaphragm. However, we can clearly see the continuality between the lateral and the medial aspects of the left hemidiaphragm paravertebrally to the spine. So if we look at this a little bit more closely, we have a veil-like appearance of the left lung due to the obscuring of the left heart border. So these are going to be consistent with the typical appearance of a left upper lobe collapse, and we can also see in this patient a mass which is just visible to the left hilum causing this collapse. So note that in adults, a collapsed lobe should be considered due to lung cancer until proven otherwise. In the next example of right middle lobe atelectasis, we can see blurring or a silhouette sign of the right heart border, which is consistent with middle lobe collapse. We can also see the presence of our air bronchiograms, and we can note that both the right and left hemidiaphragms are roughly at the same vertebral level. However, what we cannot differentiate in this patient is the location of the horizontal fissure. This is a difficult case because, like other cases of atelectasis, the collapse may be confused with a right middle lung pneumonia. Accordingly, a lateral radiograph may be more informative. In the scan, we can see a collapsed right lower lobe, as indicated by the orange arrows. This is going to result in a triangular opacity within the posterior medial part of the right hemithorax. So tracing this over here, we can see that the right hemidiaphragmatic outline is lost as indicated by the blue line, and we can see a significant reduction in the volume of the right lung. In contrast, on the left, we can clearly delineate the left cardiophrenic recess or sulcus. However, on the right, we can clearly see that this is not possible. As a result of right lower lobe collapse, you will also find that the right hilum is going to be depressed, and the descending aspect of the right lower lobe pulmonary artery is not going to be visible. So note, however, that the right heart border can still clearly be visualized, and this is contacted by the right middle lobe, which indicates and isolates that this collapse is localized to the right lower lobe. In addition, we can see pulling of the airways and the trachea, as well as the carina to the right. So as a rule of thumb, if there is volume loss, usually the airways is pulled to the side of the lung that is implicated. And then lastly, just finishing off the atelectasis section with left lower lobe collapse, we can see pristine right heart borders. The right hemidiaphragm is pristine. However, as soon as we start looking at the midline and the left side, we can see loss of the left hemidiaphragm, as outlined in blue, with where the normal position should be. The main features to be observed include a triangular opacity in the posteromedial aspect of the left lung. The edge of the collapsed lung may create a double cardiac contour, as illustrated by the orange or yellow arrows. In addition to loss of the normal left hemidiaphragmatic outline, we can also see loss of the descending aorta, which we can no longer see in this patient. We can also see lack of visualization of the vertebral bodies. This is an example then of complete left lung hemithorax. So in this supine chest x-ray in an intubated patient, we can see that an endotracheal tube has been located into the right main bronchus, probably just past the origin of the right upper lobe bronchus, and accordingly there is associated complete atelectasis of the left lung. So as it should be obvious, we can see that there is a complete reduced volume, and accordingly, if we trace the trachea here, your right and left main bronchus, we can see pulling again towards the affected side, which is going to be the left lung. So your key investigative signs are going to be to look for signs of volume loss, which are often going to be affiliated with a pooled mass effect, as well as increased opacity within your field of view. So you might be wondering then, how can I differentiate if we're looking at consolidation or a collapse? The key differential really is going to be looking at volume. So if you see a volume loss, this is then going to be accompanied with an ipsilateral shift, so shift to the same side of the airways, and usually you'll also find a change to the location of the apex of the hilum. In pneumonia, however, you will either have a normal volume or, if anything, an increased or enlargement of the lungs. In addition, you should not see any pulling or pushing of the airways. However, if it is present, it's usually going to be to the contralateral side, so it's going to be pushing rather than pulling. And then lastly, it's not going to be centered at the hilum. So I'll give you a second to try and interpret these two radiographs. So we're looking for which patient has a punctured lung, or in other words, trying to examine which patient has a pneumothorax. So if we look at a magnified version of the radiograph A, what we're looking for is displacement of the parietal pleura. So as indicated here by the green line, we can see our fine lining of the parietal pleura, and that means that in the area superior to this, we have the introduction of air in the apical segment. So it may be difficult to visualize this, but it is a very important diagnosis to make. We can see that this air is located external to the lung margin. And in addition, if we're assessing the appearance of the superior or apical aspect of the lung, we can see that we don't have any presence of pulmonary vasculature or vessels extending into the space, in contrast to this area below. Patient B, on the other hand, has fibrosis of the right lung apex. This in turn has led to a clear reduction in the lung volume, as well as elevation of the diaphragm on that side. So this was caused by radiation-induced fibrosis. Usually with a PA or an erect patient position, air will always be sitting superior or at the apex of the lungs. And as a result, you shouldn't see the increase or the lifting of the hemidiaphragm on that side. So just sticking with the theme of pneumothorax, remember that pneumothorax is defined as the presence of gas or air within a pleural space. So when this collection of gas is constantly enlarging with resulting compression of the mediastinal structures, it can be life-threatening, and it is known as tension pneumothorax. In this specific example, so what we're looking for in terms of our assessment of the apical segments of both the left and right lungs is we have this region superiorly which is going to be hypodense in comparison to the remainder of the lung parenchyma. In terms of tracing the parietal pleura, we can clearly see the lining corresponding to the mouth, and as a result, everything superior to this is going to be air. This once again is confirmed by the lack of pulmonary vasculature extending into this region. If we consider the other side, we can actually see that the left lung also has a small pneumothorax. So over here we can visualize the displacement of the left parietal pleura, and accordingly there is a smaller region of air just superior to the left apex. So in this patient we would say that he has small apical pneumothoraces in both sides of the lungs. It can also be noted that the lining of the parietal pleura is also going to follow very close to the edge of the ribs. So in your assessment, it might be worth actually visualizing or tracing each rib to visualize if there is displacement of this pleura. And then lastly, I just want to conclude with discussing chronic obstructive pulmonary disease. So this represents a wide spectrum of obstructive airway diseases, and it includes two key components which are going to be chronic bronchitis, so small airways disease, as well as emphysema. The key findings associated with COPD is going to be enlargement of the lung fields due to hyperexpansion. So as discussed in my lightboard video, hyperexpansion of the lungs will usually result in a lowering or flattening of the hemidiaphragms. In addition, if we're counting the ribs 8 and below, so 8 to 12, will usually intersect the diaphragm. In addition, the cardiothoracic ratio is going to be altered. Furthermore, we can see the prominence of the hilar vessels in pulmonary hypertension. And if we then attempt to break this down further into the two main components, the findings associated with chronic bronchitis on chest radiographs is going to be non-specific. So this will include increased bronchodilatory markings as well as cardiomegaly, which will be the enlargement of the heart. Emphysema, on the other hand, is going to manifest as lung hyperinflation with flattening of the hemidiaphragms, which we can see in this particular individual. As a consequence of this, the heart is going to be less magnified or smaller, and in particular patients, you can see possible bullous changes. So I hope that this video has provided you with a clearer indication of how to recognize abnormal chest radiographs and provided you with the competencies to be able to recognize abnormalities in the form of consolidation and lung collapse by tracing the cardiomediastinal contours as well as the hemidiaphragms, and also become familiar with the assessment of pneumothorax, so looking for key areas of the introduction of air or gas, and then lastly finishing off with COPD and emphysema.